through distal humerus fractures. And so for those of you who don't know, today we'll have a couple different people talking about these. So Carolyn's out of Cedars-Sinai, she's on. I think I just saw John Scalaro show up, and I probably able to hear him in a second.
You hear me,
John?
Yep.
Oh, there he is.
Perfect.
And then Dr. Daphne Beingessner is also here at Harborview. She's currently in the operating room in a sort of an unexpected way. So we'll try and see if she can call in a little bit, but we'll get started without her. So that being said, this is meant to be interactive between the attendings and the residents. If you guys have questions as far as the residents go, this is a learning opportunity, right? We like talking about cases, but we also want to make sure we're answering your questions. Don't hesitate to ask those questions. Don't feel like there's any questions that you don't want to ask. I know it's a big forum, but the goal of this is really to go over things that may not be clear, or also how, different people do different things. You'll see a variety of ways of doing the same thing. And so sometimes, understanding why, Dr. Scalaro does his osteotomies a certain way versus the way I do them, or versus, other thoughts or things that you may have seen in your residency. So don't hesitate, type them in the chat, because it's probably easier to deal with them in that sense. And then we'll be happy to talk a little bit about them. So without further ado, all right, so I'm gonna start. This is one of my cases. This is a 35-year-old female who was racing against life. So basically was on meth and alcohol and got into a car and was on the highway, and then was going pretty fast, I think 110 miles an hour, and hit a wall. And so this is what we have in the trauma room, or in trauma bay, as far as her x-rays. John, what do you think? You see this, what's your first thoughts, just looking at it right off the bat?
So again, just making sure that this is a closed injury. Obviously, you see the displacement, the distal aspect of the proximal fragment. In the in the pediatric population, these are a lot more prone to neurovascular injuries. The adult population seems to be a little bit more forgiving. So again, I think a good neurovascular exam is key when you see the anterior displacement of the shaft here, and then after that. Once I get a good, neurologic exam, just hoping that one of my residents decides that they're going to grab the wrist and pull on it and give me a traction view, that would be really helpful here. And then after that, in terms of, initial management or initial treatment, they're just going to get it splinted in a position of comfort, as long as there's nothing else weird going on.
Okay. So, you're pretty lucky, because you've trained your residents nicely, and they've gotten a lot of education out of you, and they do this. This is what you get.
Okay.
Does this give you any more information or less information? Or are you more confused now?
No, not really. If you go back, one image, there's a couple areas where just picking up on small things, over the course of time, can you guys, I don't know if you can see my pointer, but if you look at the lateral column, there's a small fracture right above the capitellum there. So that, if you're looking for, clues in terms of how you're going to treat this, realize that looks like it's kind of an incomplete fracture up the column there. The other area where I may ask for some further imaging is if I see something on the lateral, specifically in the capitellum, that doesn't necessarily make sense to me. So if I see some irregularity in the capitellum, I don't see anything here on this one. I see two, kind of nice overlap with the capitellum and the trochlea. And then sometimes there'll be impaction in the central, where the central fracture is, where the central split is. And so, again, I don't see it here, but those are the only other reasons that I'd consider getting some further imaging outside of this. Other than that, this tells me pretty much all I need to know, I think. Okay.
Carol, how do you feel about that? Are you a traction viewer? Are you a CT scan? Or are you just blind faith, go to the OR with that first x-ray?
I personally like to have as much information as I can. And so I'm a believer in both, actually, especially if I think this looks like it's a fluoro view, but we'll often try to get traction views, before, and then also then splint and then get a CT scan to better appreciate what's going on in the center of the joint, as John was saying. Sometimes you can have unappreciated areas of impaction or small fragments where what looks like it could be a simple split actually ends up being a multi-fragmentary joint, and that kind of helps you plan ahead.
Yeah, I think that's super important. So I agree, John, that fragment on the lateral side, that incomplete or that minimally displaced fracture that you think, oh, this is going to be easy to reduce the whole lateral column, all of a sudden the capitellum is not attached to it. So I think it's good to know preoperatively. So either you kind of go in there and stabilize it before you move it, or at least look for that fracture. The other thing, and I don't know if I'm the only one, I find this often happens on the medial side also. So right above,
so it exits down, not as high. It comes down toward the angle of the where the ulnar nerve comes around through the tunnel. Yeah, right there. That's
right.
That's what I see. I think probably the most frequently is I'm all juiced up because I know that I can just take the medial column and put it right back, and then I do, and then the trochlea is still pushed up and not congruent with the proximal ulna.
Right, and I think that's a really good point. So it's not, so for the residents, we see this, we're like, yes, this is easy. I'm going to bring this back to here. There's a nice clickable surface, and then I can turn this into a simple B type. But if this fracture exits here or exits here, usually it goes right along the trochlea. What happens is this trochlea is actually impacted up and angulated, and so you reduce this, and then you reduce this, and then the joint doesn't match, right? So I don't know if I'm the only one that's happened to, but basically, because there's a lot of impaction, or it's rotation, I guess, or it's impacted up on the lateral side of the medial trochlea. It basically looks right, but then when you go back and looking at it, it doesn't line up in the operating room at the level of the joint. So for me, those are the ones that I've gone to take, to get more CT scans preoperatively, whether or not that's right. I know Dr. Gardner often gives me a hard time for it, just because it's a poor utilization of resources. But I'm more of Carol's opinion. Like, more information for me is better, and so that's what I tend to do. I'm just wondering. So we know John probably wouldn't get a CT scan. Carol said she would get one. I was wondering if anybody else, any other attendings on the call, maybe. I know Michael Giffens is on. I know Dr. Gardner's on. I know Dr. Little is on. I saw David Shearer's on as well.
As mentioned, you can't see the details of the capitellum without a CT scan, and sometimes that will come back to hurt you.
That's my boy, Julius. That's my boy. I like it.
I get it as well, because same thing you said, that capitellum, the capitellum issues, and then that impaction.
No CT scan, waste of time and money. I mean, you're gonna be looking. I agree with all the common locations of these fracture lines, and you can look at them directly and react to them if they're there. Like, it helps if there's a question of a coronal plane fracture that may need a different approach or something else. But these kind of fracture lines that are possible here, although very unlikely based on what you see. I mean, there's a good traction view. I just don't think it changes anything that you do.
Fair enough. At least you're consistent. So here obviously, because I treated this patient, got a CT scan, and the one thing that you'll see is actually kind of what John was alluding to, is that sort of incomplete fracture line going there, and then there's another one right here. Mm-hmm. And so to me, those are really the ones that I like planning on them beforehand, knowing, okay, this is undisplaced or it's actually displaced. I'm going to wire it first or reduce that first, basically pull this out to length, and doing all that. So, okay. So John, now we have this is the full picture. What do you do? I'm going to go back to the traction view just so we can make sure we have a whole view there. But what are you taking this to the operating room? When do you take this to the operating room?
Closed injury.
Closed injury.
Whenever I have patients and I've had good solid Americano, I'm gonna make it and be good to go. It's just not one that I'm gonna start 7, 8 p.m. in the evening with this, with the C team here, because it requires patience. It can be a little bit frustrating, and you don't want to, for me, there's no urgency or emergency to take this. So,
John, you admit the patient, or is this somebody you can send out and come back?
No, I'd admit him. I've had too many flusters here with, people leaving and then not having the right insurance or having difficulty getting back in or scheduling. I don't know. I admit them. I'll just take care of them. I'll make time in my schedule to do them.
I admit them as well.
Yeah, I mean, we definitely admit them. I think to further to John's point, this is a complex injury, and starting this at 8 o'clock at night is probably not the best idea. And I don't know that there's an urgency unless there's a compartment or a vascular injury associated with that distal portion of the proximal shaft extending distally. But I think we keep them and we do them sort of as soon as they're okay to go without in a good overall environment.
And then
I think
go ahead. Sorry.
Yep. Sorry. Yeah. I think the other argument is if you discharge these patients, it's such a grossly unstable fracture that we don't typically harp on the soft tissue conditions as often in the upper extremity as we would for like a plafond or something like that. But for someone to have this splinted and then you get up and you walk around for a couple of days, within 3 or 4 days, that elbow and forearm skin is really indurated, edematous, and then it becomes actually kind of an unsafe situation to fix it because it's going to take a fairly extensive amount of work.
Yeah, I totally agree.
And then setup for me is going to be lateral decubitus position, direct posterior, and I think there's been a couple of things that have changed over the course of 7 years, and I think I've gotten a little bit better at doing intra-articular work without an osteotomy. So, if anything, we're kind of talking about the role of a CT scan. Sometimes the CT scan, it may help me make that decision right away to go to an osteotomy and not muck around for, 30 minutes. Or, sometimes it'll tell me right off the bat that I be able to kind of do it without. So I'm going to try without on this one. I think I can, even if there's a little bit of impaction in the trochlea, I can disimpact it through medial and lateral windows and work on the joint without an osteotomy. So that's my vote.
Okay. Walk me through this, because I have trouble often deciding. And usually what I'll do is I'll set like a time limit of how much time we're willing to mess around in the joint. And then usually we hit that time and I'm like, well, we should have done the osteotomy an hour ago, but end up doing it. So what are some cues, like for the residents, like that you look at when you look at either the CT or the traction view or something that it says, there's no way I can get this without an osteotomy?
The more central the fracture fragment, the more displaced or rotated, or if there's anything that seems to come more anterior in the trochlea and capitulum, will send me to doing an osteotomy almost immediately. That's not a great area for me to visualize. If it's just maneuvering the capitulum or the trochlea as a whole, or if there's a simple read posteriorly, then I'm less likely to. But the more things go anteriorly and the more they're displaced or flipped or rotated, that tends to push me more towards an osteotomy right away.
Got it. Carol, what about you?
I have a very low threshold to just go straight to an osteotomy. I mean, you talk about a time limit on how long you're willing to forego it, and mine's about 5 minutes. Especially if I can see, I'll get down there and you kind of look at the approach, and then you can kind of look at the joint from both sides. And if usually by that time, especially if I know there's really more than a simple joint line fracture, then I tend to go straight to the osteotomy. As John was kind of mentioning, time is not just the time of the surgery to the patient, but there's also your psychological factor of struggling through something for 4 or 5 hours. You get mental fatigue and you're not really on top of your game. And for me, I don't want to spend an hour struggling and then doing the osteotomy, and to find out that reduction I thought was perfect was still not quite perfect, and having to go back stick to that step. So I'm an osteotomizer. I'm a olecranon hater, apparently.
I'll agree with you. I don't know if you could see. So for me, the ones that have the comminution right in the sort of central part, if there's any segmental piece, for whatever reason, I found that it's very difficult because the piece can be rotated and it's extremely hard. Like for instance, let's say there was another fracture line right down the middle here, and this central piece, the central piece was completely free. Just getting that to rotate in the right direction without visualizing it completely, or at least 270 degrees of it, I found it's very difficult to judge and hold and maintain that reduction. So anything simpler than that, or more complicated than a simple pattern, I will tend to do the osteotomy very quickly.
And I would add, if there's a coronal component to it, a lot of times you'll have this a flexion moment, or it's anteriorly comminuted, and it's very hard to judge your flexion extension. I think keeping the olecranon on and you're just looking at the fracture from the sides obliquely, you're never really able to look at the fracture line straight on, or the fossa straight on, to see what your reduction is. It's just much more challenging.
100% agree. Yeah. So, John, what's your reduction strategy then with this case?
Yeah, so I think you have two approaches. You can either take a C type, with intra-articular extension, put the joint back together, and then convert it to an A type fracture and just work on the metaphysis. Or if you feel that you have a good read along one of the columns, you take the C type and then convert it to a B type and make it a partial articular fracture, and go from there. And that, a lot of times, that just depends on the continuity of the columns for me. So if I can get a good read on a column and it's all intact and I'm confident with it, then I'll work on a column and then hook the other side of the joint up to it. I find it's very hard to I shouldn't say I find it very hard. I find it more difficult to adjust and hold flexion and extension of the articular spool if I work on the joint first and then try to just kind of float it to the metaphysis. And those are the ones that can be very challenging. The distal humeruses, that can be very challenging if you don't have a read on the medial lateral column and you're just kind of floating the spool in space. Those still trouble me for sure.
Right, because I mean, as I've learned the painful way, you can malreduce those in at least 4 different ways, right? Flexion, extension, rotation, varus valgus, and then you can also sort of in the axial plane angulate them back and forth. So you can over reduce the back, because that's the tendency, just to put the clamp on the back. So I think you're 100% right. If there's that column read, I love that, right? Because you can at least build something back to it. It gives you an idea, and then you can tweak it, especially if, like this one, there's a fracture line that goes through that medial side and that the joint is impacted. And then what kind of platings are you going to do with this?
In general, I'm a parallel plater. I've moved away from orthogonal plating in general, so it's going to get a medial column plate and a lateral column plate. Oftentimes, I think as many of the faculty on this call have moved towards, I think there's a nice use of our ability to use mini fragment plates like clamps in order to provide adjunctive fixation or increased stabilization, potentially along the posterior lateral column or something like that, where you'd previously put a dominant plate.
Yeah. All right, I kind of agree with all that said. So why don't we just take a look at what was done. So this is my case. I'll take you through it. So here's sort of how I set up. Position is the same thing as you, sort of lateral decubitus over an arm, radiolucent arm board. Here I decided that we were going to do an osteotomy because of that comminution. I wasn't sure. So I usually drill the central part of the osteotomy using a 2.5 drill to the bare area or bare spot, and then I do the osteotomy after having plated it. So I'll put my plate on first, take the plate off, and then do the osteotomy. I found that after, for this one, not so bad, but if it's a really smashed distal humerus, after 4 or 5 hours of mucking around with the joint, if I have to reduce another fracture, I lose it. So having the plate on already is an easier way to get this done, at least in my hands. And then I finish the osteotomy, and then we move on to the reduction. So I tend to do kind of exactly what you say. I actually go from a C to a BA at the same time. Like, I don't know what the right term is, but I'll work the joint, work the columns back and forward. And then you can see on the AP sort of getting that joint just right, wiring the column to help as a leverage point to fix the internal rotation and also the flexion extension. And we talk a lot about the anterohumeral line intersecting. I often will look at the contralateral side too, because not everybody's 30 degrees flexed, although that's sort of a good general indication. And then I'll lag the joint. You can see those 2 lag screws in the distal segment. And then I love using that little mini fragment plate as a adjunct stabilization that'll allow me to remove some of my wires and then get the medial plate on, get the posterolateral plate on. And I don't tend to use this posterolateral plate anymore. I'll use the one with an adjunct on the lateral side. So it has a kind of a tab running around the lateral side. So it gets a little bit of your parallel plating screw trajectory as well as the posterior vector of that plate. So maybe best of both worlds, I don't know. But that's sort of what I do now. And then you can see here's what it looks like when it's all done. And then here's the finals x-ray. So I think that covers sort of a basic distal humerus
That looks nice.
type.
I think for the residents, oftentimes realize there's a lot of real estate anterior in the spool, and so we're used to placing our implants. And in general, even when you put a medial and lateral plate on, they tend to sit a little bit more posteriorly. But there's a reasonable amount of real estate. And here I find it very helpful just to ensure that you get a good lateral. Good lateral is working with fluoroscopy, getting a good lateral is a key to this, because you can really tell where you have room to put screws. So
you can kind of see it here. This is a better lateral than the final x-ray, but this plate, I push it a little bit anterior more than usual, maybe, I don't know.
Jonah,
Right.
can you talk a little bit about, just to back up, I think your strategy of fixation is, and I totally agree with that. And I think what I noticed is you often have to work between the joint and the columns back and forth. So you have to be careful not to lag stuff too early, because I've definitely gotten into that situation where you thought it was simple and you just lag the joint together thinking, okay, I'm done with the joint. It's now a type. And then you find out you're slightly off or the joint isn't congruent. And so there's a lot of wiring and provisional fixation before you start locking stuff down, because you're often finding, having to slightly adjust the reduction back and forth in both of the zones. But question I have for you, how do you, and maybe we'll get to this later, but how do you handle the ligament origins to get those plates on? And then also, how do you handle the nerve?
Yeah, it's a good question. So I just do an in situ decompression of the nerve, move it out of the way, and then at the end of the case, I put it back on. When I lift off the tissue on the medial side, the ligament actually inserts a little bit more anteriorly. So I usually stay away from it. I'll lift off the the flexor pronator mass, origin on the medial side as a sling, put the plate on, and then close it back over top, and then put the nerve back over that or posterior to that. So everything is sort of sitting on soft tissue so that it doesn't irritate on metal. I don't routinely transpose the nerve unless there's really good indication. There's a lot of literature out there that shows that there's no real difference at this point. And I feel like it devascularizes the nerve a little bit more to release it that much. So I try to keep some soft tissue on it, move it to the side, and then put it back at the end. So that's for the nerve. For the ligaments on the lateral side, you usually don't have to take off the ligaments just because they're fairly distal. And on the medial side, they're a little bit more anterior. So as long as you're careful and lift everything off as a sleeve and repair it back down, if ever you do get into the ligaments, you should be okay. And that's basically it.
What about you, John? You like parallel plating, so oftentimes that lateral plate, it can come pretty distal. I mean, it comes right on the center of the lateral portion of the capitellum. You're sort of abutting the ligaments.
I just put it right on top.
You just smash them down. Okay.
Yeah, put them right on top. I don't lift them. I don't lift them off, and I haven't had issues with that. And the same thing with Jonah. I don't I don't decompress or transpose the nerve. I mean, so I just free it up, make sure it's free, try to keep a sling of soft tissue that I can put back on top, and keep it away from sitting directly on the plate. I do everything I can to keep it from actually sitting directly on the plate. Yeah.
All right. So I think just a couple of take homes from the first case, sort of a basic C-type, very simple, but it helps to hit all the points home. I think the traction view is extremely helpful to identify all those things. And if you can't figure out the fracture, I like getting more imaging. I think CT scans can be helpful, especially 3D, reconstructions if you're not sure. And look for those incomplete fracture patterns, especially on the medial and lateral columns, to not overthink that something is going to be an easy B-type reduction. I think the reduction strategy, transforming a C-type to an A-type or a C-type to a B-type, any of those two can work. More likely, it's going to be like in between those two. So I try to get the joint right and then kind of get the columns right and then work my way back and forth. And then the other thing that we didn't talk about, but happens very frequently, is because you're looking at the back of the humerus, and we tend to put clamps on the back, you can overextend it. And so, the last thing I would do before sort of buying the reduction is always make sure on the lateral that it looks like we've restored the flexion extension axis nicely. And then I think, we always fix these with minimum 2 plates. Oftentimes you'll see 3 or 4, including some little mini fragment plates. And I like to base this on the pattern. So I know John talked about putting these more parallel now, but I think there's some fractures that I like doing more parallel plating, the ones with more of a coronal or, a shear type of a fractional-sagittal split, versus other ones where I think I'd like to get longer screws into the capitellum. So I try to adapt it based on that. But whatever it is, I like to create stability to allow early range of motion. I think that's key for all elbow fractures. To keep in mind. So if the fixation isn't there to allow range of motion, then we're not doing the right surgery. Any questions for this case? All right, John, this is your case, correct?
Yeah. So this is a 18-year-old female who's involved in a high-speed motor vehicle collision. She had an isolated upper extremity injury. I think these were the initial films that were obtained that she came into clinic with, and the challenge here is that at this point she was almost 3 weeks out. So she's been 18 years old, 3 weeks out, and this is what she was splinted, or I think these must be the original ones because it looks like there's an IV in there. I can't remember, Joan. Is there anything else, or does it just go right to CT?
No, there's your favorite thing to do.
Okay. Yeah, there we go. So this is our attempt at a traction view, and in reality, this was actually right before we started her surgical procedure. But she's now 2.5 some. We saw her two some weeks out. We operated on her like 3 weeks or so. You can see the cal starting to form between some of the proximal fracture fragments. So I don't know.
You think
Carol,
Michael Gardner? You think Michael Gardner would get a CT on this one?
I don't know. Mike Gardner, you want to get a CT on this?
Yeah, I mean, this traction view makes things a little less clear. I mean, still, and there's some maybe coronal plane issues. So yeah, probably get a CT. Fewer big pieces.
That's all Jonah asked me. He goes, just find one that Gardner would get a CT. Mission accomplished.
Charles Chuck Moon, he basically gives us his description of this fracture as ouch. So I think that's a good that's a good qualifier. Anybody who sees this on the faculty knows that this is pain train waiting to happen. Carol, what are you gonna do with this?
Block out a good long period of time. I totally agree with the CT. I get a CT anyway, even if it wasn't, that's my normal protocol, I suppose. And I think this is something it's got some concerning factors there. Again, there's this coronal component you can see on the lateral where the radial head and the capitellum are not really pointing at each other anymore. So there's a dislocation component. Makes me think there's something going on for sure there with the capitellum. And this is something where I would be ready to have lots of little articular screws, buried screws ready, because I think you're going to have to really look at the joint surface. And then you kind of have to think, okay, you know, there's a columnar component, there is a probably intra-articular component, there may be a coronal component. So then how are you going to see all of that? Is an olecranon osteotomy going to accomplish that, or is this something where you actually have to get very anterior in the anterior column, and the lateral column, because is there this like a capitellar coronal component like we were discussing in the prior case? So I think a CT would help me a lot with that.
All right, I'll show you the CT, and you can keep thinking about what to do.
Oh.
Yeah, yeah. That's terrible.
My ouch.
It's a lot of sadness. Yeah.
So it says 2 weeks here, but it's more like 2.5 weeks. I think maybe by the time he operates, 3 weeks. So, I mean, you make a great point, right? So how do you see the coronal shear from the back with the osteotomy? Because it doesn't, I mean, even if you hyperflex the elbow, in this case, it's all sort of jumbled anyways, but how do you get around the front?
Is that directed towards anyone?
I mean,
I know how I did. I know how I did it.
I know how you did it, but like,
fun.
just in general, I mean, Carol, what do you think? Because you're talking about how to get around that you know, to that front piece. How would you do that?
I know, you know, this is why I kind of asked you guys about the ligament issue. There have been times when it's been very comminuted where I've just peeled everything off of the medial and lateral columns, and then you can really, then you're actually, you know, if you peel the origins off of the very distal portions, you can come around and look at the front of the capitellum. It's not as good as a lateral column approach where you can actually look at the very front of the joint directly. You know, I think though with these, if you do enough soft tissue dissection, the instability is not something that I have seen with these fractures long term, and so I have less of a I'm more willing to be aggressive in peeling all that soft tissue off so I can see around where I need to go.
You know, my alternative in that scenario is if you've got a lateral epicondylar fracture, you just mobilize that fracture fragment and flip it out of the way. If you don't, you can do a lateral epicondylar osteotomy and flip it out of the way. And then you have a really nice view, especially if you do that and flex the elbow to 90. You can see the capitellar fragment really well without doing a big soft tissue release. And then you've got those bony surfaces to fix and get to heal. So I think there's probably alternative, different ways to do it. But yeah, I think exploiting the fracture, doing an osteotomy works pretty well.
And Mike, that's with an olecranon osteotomy, yes? That's in conjunction with an olecranon osteotomy?
If needed, depending on the fracture pattern, but yeah.
Okay.
Yeah, I mean, I've done that technique that Mike talks about for a capitellar shear, like an isolated capitellum, you know, from the front if you still can't get enough visualization. So I think it's a great adjunct in these ones. Peeling off all of the ligament and soft tissue is probably okay. You know, they don't end up being unstable, but I think if you have a little epicondyle fracture or you can create a little osteotomy, then everything kind of peels away anteriorly, and then you can actually just kind of do like your column approach and see basically 360 degrees on the capitellum. Doesn't mean it's going to be easier to fix, but at least you can know that it's malreduced if you're doing it, you know. All right, so John, what was particularly, obviously, you know, this is a long, you know, delay for these cases. Even in the early setting, this would be a hard case, but at 2+ weeks, what are your sort of, what were you getting ready, or how are you, you know, anticipating trying to get, you know, around that or trying to help out with that? Is there anything that you can do to plan or to do anything, or is just kind of just set aside your whole day and just go at it?
Yeah, I just started first thing in the morning and realized that, you know, I think one of the things for me was just making sure I was really careful with the nerve, mobilizing the nerve as carefully as I could, knowing that there was going to be, you know, callus and kind of organizing hematoma and stuff like that. And then, for me, especially after seeing the CT, saved myself any amount of struggle time without an osteotomy. Went right to an osteotomy, and then it was just slow. And I think the first thing, just to address the hardest thing first. And so I went after the capitulum. I did something similar to what Mike Giddens mentioned, and just rotated the capitulum out first. There we go. Mobilized the capitulum first, rotated it out, and then reduced it, and then put some screws in it, put some independent screws in. I apologize for the lack of fluoros. This was 2014, so it was a little while ago. And then used a dual plate, restored the column on the medial side, and then kind of fixed her all up. So,
I mean, that looks great. That's like that's a great effort.
The question that I have for the group, and maybe this is someone to answer, is you had utilized some countersunk 2.0 screws. Does anyone put anything bioabsorbable or similar in some of these fracture fragments? Because it never looks as sunk as it does in the operating room. And so even though long term it didn't end up giving this person a problem, I would love to put something that would hold, and then not have to worry about it later. Has anyone mucked around with anything differently?
Yeah.
Not so much. I have for not in the elbow, but I think their purchase and their torque strength, they just don't seem to have the same amount of purchase as a metal subchondral screw can achieve.
I've put some of these resorbable K wires for some of these. The PLLA K wires, just kind of put them in and you cut them flush. They seem to stay okay, but I don't know if that's just wishful thinking or not, but it does tend to help a little bit to stabilize it, at least initially in the operating room, and you definitely can't see it on the post-op x-ray, so that's helpful.
And then last question.
I've done the same thing. I've done the same thing. There's little PLA K wires you can just kind of bogey the excess off. Okay. I don't trust them for like definitive fixation, but just to hold something in place,
Does anyone care at all anymore about where these plates end up in terms of being same level, different level? I feel like I used to care, and now I don't care anymore.
I don't care. I put the right plate for the right, ending them at different lengths. I mean, the theoretical risk is that, you're increasing stress riser that they break there, but I don't know that that's necessarily fact. I think that's just dogma. Okay.
I still try to do at least one hole. But
it scares me in older patients that have kind of not great bone, if you get two fairly, and it depends on which plates too. I mean, some of these are definitely stiffer than others, right? Like some of them have a lot more flex than some of the others, but I have two fairly stiff stainless plates in the patients, 70, that worries me a little bit, but I guess in this patient, I wouldn't worry too much.
In that 7-year-old, if you have this instead of two plates ending here, I just think the fracture is going to go like that instead of going like this. But I don't know that to be true. But I think I certainly wouldn't dissect more proximally in risk, nerve or something like that. If I only had this visualization, I would just take that.
Very reasonable.
So this one doesn't quite end right here. I mean, where the next slide is. No, it's not a big but she did have some ulnar nerve symptoms, and management. They continued to get better with time, but she was 18, and they didn't go away completely.
1 second, sorry.
I just got a whole lot of Chuck.
Carol.
What's up? Looking very chill in your office there, Chuck. That's your Zen background. I like it.
I'm going for the
All right.
Dave Colbert effect. I think that guy's still in Punta Mita. I don't think he's come back yet.
All right. Sorry.
So she continued to have some ulnar nerve symptoms. We got all her motion back.
Wow.
But decided to go in and do a formal ulnar nerve transposition, and then removed her medial plate. So, and then her olecranon plate. She was pretty thin. So I just took her medial plate out, and then this one always kills me. I mean, she didn't have any symptoms on the lateral side. I think that screw was not directly anterior, but you know, I swear on my mother's grave that thing was well countersunk, and it's it definitely looks a touch.
Blame the X-ray.
Yeah.
It's not a perfect lateral.
It's not a perfect lateral.
No.
But I mean, it's hard to argue with her result, right? Like, here's her result. So
Wow, that's impressive.
I think that's a really good result.
If you look at her, if you're really critical, look at her hand, and she's got her little ulnar nerve. You can see the right side was her affected side, and she's got her little ulnar nerve splint that OT made on her.
Yeah.
On herself. But she got her motion back, and actually, she's, like I said, she was in 2014, so she ended up doing very well, all in all. But anyway, yeah,
That's
one where you need
a
to
great
cure
case
on that capitellum.
Yeah, that's a great case, John. So I think take homes for me, anyways, from this case, looking at it is, these complex fractures, the first reaction of everybody seeing that CT was that this is really intimidating. But if you just settle down and say, you know what, I'm just going to go to work and, just do whatever, block out the whole day if I need to, usually we're able to make something look reasonable. It's basically the same principles, but we just expand it, right? So, figuring out how to get access to that capitellum can sometimes be challenging. Looking at these, different ways, either elevating the soft tissue or doing an osteotomy can be helpful. And so, and then for these ones, obviously don't waste time not doing the olecranon osteotomy off the bat. I think, know when it's potentially achievable, when it's not achievable, and don't mess around with it.
It's interesting, Jonah, even after the formal ulnar nerve transposition, it still took her over like a year for everything to completely go away. So this is almost, we're talking about radial nerve patients and humeral shaft fractures. Just be patient with a lot of these folks. Even if they have a little bit of neuritis immediately post-operatively, don't sweat, because a vast majority of them will go away.
Yeah, agreed. All right, Carol, is this your case?
Yeah. So this is just around Christmas, I think 2 or 3 years ago. It's a 91-year-old woman, happens to be the mother of an orthopedic surgeon, visiting from the Midwest. And she has a ground level fall at the Beverly Center. Actually incredibly healthy. Like, she doesn't take any medication. She actually still swims fairly regularly. And she has this injury. It's an isolated injury. Everything else is okay. And there is a little poke hole right out the back, right there where the red arrow is. So, kind of going through the steps of preparation, would anybody get any additional workup or imaging for this patient?
I mean, I can tell you, for me, 91 years old with a distal humerus fracture, just with the quality of bone, the location of the fracture, the risk of these being sort of terrible, I almost always systematically get a CT, because it allows me to figure out if I think I can fix this or if I think they'd be better with a replacement. So that's my sort of algorithm. But I again, I don't know that that's the best way to do it. I just think that that's what I've been doing.
Yeah, I think if you want to go back to the original injury films, I mean, if you kind of look at it the way it is, it doesn't look that bad. Like, it looks like kind of like that very first case that we had, where it looks like you can build back to the columns, and the joint surface actually looks like it's relatively together. It's not in a million little pieces. Hard to say, but you can kind of identify there's a capitellum and a trochlea, and maybe that's something where you could put back together. But yeah, so this is something. Would anybody else do anything differently? Yes.
Sorry, I had to click off for a second.
John, would you get a CT on this? Or would you do anything traction view first before you decide on a CT?
I'd probably just get a traction view just to see
Okay.
what's going on. I think the ultimate decision here is, biggest decision is figuring out what her demand on that upper extremity is, and then if you need to involve someone, if you are okay fixing it, then fantastic. If you have to think about replacement, then you just want to have that discussion early. I've only done one total elbow, so I'd have to call one of my upper extremity partners to just be around if I thought there was any chance that this was gonna not be fixation. But I'll tell you, I'm pretty aggressive in terms of fixing a lot of these, just in general.
Yeah, so when I looked at this initially, I thought, okay, she's 91, but she's actually a pretty active 91. She lives by herself. She travels back and forth between the Midwest and LA, and she's from the Midwest and not LA, so we know that she's actually tougher than the average LA person in terms of just pushing through whatever comes her way. And so I actually was thinking, yeah, I think this is really might be amenable to fixation, even though she's 91. But then I did get a CT scan because I was suspicious about the capitellum there. It looks like there may be some fragmentation versus soft tissue shadowing. And then there's always that secret impaction right at the middle of the joint. And then as you had mentioned before, that separate trochlear piece that might just be not attached right at the corner of the epicondyle. And so you can see here on the CT scan, the center of the joint is actually pretty straightforward, but everything is its own independent piece. And the capitellum itself is also kind of floating and comminuted off of its origin.
Hey, Jonah, this is this case, but then also other cases as well. Look at that bottom right-hand image, and you see the trochlea there, and right where the olecranon fossa is kind of coming down, you see where that hinge is broken and the trochlea is extended a little bit. That's one of the things that for the residents, when you're fixing these, if you're looking on that lateral view and the whole spool is just doesn't seem to sit in the correct position, it's extended, the spool's kind of in line with the shaft, that's usually where that hinge is broken. So a simple way to get around that is just placing a small roll of towels kind of just proximally on cubital fossa. Let the arm hang over just a little bit more and kind of free float, and then the forearm will usually kind of help rotate that. You may have to disimpact it if there's if the olecranon fossa has kind of impacted itself into the bone of the spool. So sometimes disimpacting it and then just getting that getting it out of that extended position can be very helpful. But that's a really nice CT image of kind of where that hinge can be broken, and it can be very troubling if you don't know that it's there.
Yeah, and the other thing is, because oftentimes we put that clamp in the back and we're looking at this, we want to squeeze this as tight as we can, and we're really just extending the whole joint. So I actually put pretty reliably 2 towel bumps underneath the the arm a little bit further up and let it kind of flex down. And it's a lot easier to correct the flexion over flex than it is if you're extended, because you won't be able to see it properly. So this is the 3D CT.
Yucky.
So Carol, because when I look at this, one of the things that pushes, so I do both, I do the total elbows and I'll fix them. And when I see this, I tend to think low fractures for me are one of the biggest indication. And when I say low, I just mean that, this fragment is not very thick. And so similar to what we talked about for proximal humerus fractures a few weeks ago, but if that head piece on the proximal humerus or this trochlear piece or the capitellar piece is very thin, then even if I can get it reduced and anatomic, I don't know how well they do with screws in that piece, right, to hold on. And so I worry about those failing, and then in a 91-year-old, if something fails, then I think to me that might have been the wrong procedure. Now I don't know how often they do, but those are the ones that I really think for. And then just looking at the comminution on the lateral side as well. to me, this is one that, you know, I would think about replacing.
Yeah, so that was definitely a consideration, and why the CT, I think, was very helpful, because it really highlights how much joint damage there is. So not only is there the trochlea and the capitellum are separate pieces, but in between there's a lot of comminution. So it would be hard to compress those two pieces together to get some additional stability. I'm like John. I like some variation of parallel plating to send those long screws across from one side of the joint to the other to recreate the triangle in the back. And if the capitellum is this, 12 millimeter shell, it's very hard to get any sort of screw purchase, even from the side or from front to back or back to front, to help resist those flexion forces, which are really high at the elbow, because it just wants to flex through the fracture instead of the actual joint. But what makes this hard is that when you're trying to decide, at least for me, and trying to decide, fix versus replace. And some people will say, well, you just have them both available in the OR and you can start trying to fix it, see what you have, preserve the extensor mechanism, and then you can just change in the middle if you realize, oh, wow, this is really not reconstructible, which is kind of how some of the comparative papers have described how patients were allocated to one group or the other. But for me, the setup is totally different. If I'm going to do a total elbow, then they're supine with a hand table. If I'm going to be doing a distal humerus fixation, then they're arm over a post in the lateral decubitus position, and it would be pretty hard to, I wouldn't want to be in the middle and then have to close everything, reposition, and reprep, because just personally, I learned to do elbow replacements in the supine position. And so this is something that I wanted to decide beforehand. And again, you can't like do an osteotomy of the olecranon and then change your mind, because now you've boxed yourself out. So we went in with the plan, as you said, to do a elbow replacement. Just, again, all those factors you mentioned: super low, small shells of bone, really difficult to reconstruct, and not just reduce, but stably fix to begin early range of motion. And that's the priority here, is do something so you can start ranging the elbow pretty quickly.
Carol, what's your discussion with when you tell the patient? I mean, she seems like she's pretty reliable with it. What do you tell her with regard to restrictions and function afterwards?
Yeah, very, very good point. So these total elbows are not like total hips and knees, where they're big, robust implants, or even total shoulders. They're pretty fragile, and they're not really meant for someone who's going to be out there, playing tennis and doing yoga and push-ups and things like that. So I spent a lot of time really trying to tease out what her activity level expectations are. And, her most impact heavy lifting activity was getting into the pool and doing the breaststroke around, 30 minutes a day. And she weighed about 90 pounds. So I had a long talk with her about what fixation would be like, the risks of failure, and the concerns. And I do tell them that you really should not be using this arm to lift anything. And if you try to give them a restriction, then I think people spend the whole time saying, is 2 gallons of milk 10 pounds? Is my backpack 10 pounds? And if you tell them just don't lift anything with that arm more than a cup of coffee, then I think that still keeps them just under the 5-10 pound limit. But I try to really reinforce that these implants for total elbows are not meant for anything but your daily self-care activities for the most part.
For the junior residents that are on, that's probably just the most important take home. These are not the same as total knees and total hips.
So Carol and Jonah and anybody else who does total elbows, in the setting of an open fracture, do you consider staging this for a washout and then a delayed total elbow? Does it depend on the size and the contamination of the open wound? How do you deal with that in the setting of an open fracture?
I'll throw that up to Jonah first.
Yeah, I've done a couple in these sort of poke hole open wounds, and then if it's a really bad one with bad contamination, I've done twice now. Basically, go in, wash, take out devitalized tissue, if there's a column fracture, fix that, then cement spacer, let it all heal, and then come back. And then if they're sort of looking like the wounds are okay and everything looks good, then I go back and do a definitive TEA later on, after that. But at least I've kind of, if there's big column fracture, I've gotten everything sort of lined up a little bit better. I haven't had one so far get infected, but that's probably just going to change for the next one I do now that I said that. So I don't know.
So Jonah, do you resect the articular components first, and that's where you put the spacer?
Yep.
And then you just leave the columns in? Okay.
Pretty much.
Yeah, so I think if I totally agree. It's totally gestalt. It's not like an evidence-based hard stop, how you decide. For this one, she had a poke hole. It was upper extremity. It was not contaminated. And for these older patients, whenever I cement things, I tend to put antibiotics in the cement, and I felt like that would be safe enough to have a protective effect. I did tell her that if we got in there and there was concern for contamination, like she got some threads of clothing in there when they reduced it and put a splint on, then we might do exactly what Jonah said, which is put some antibiotic beads or something in there and sterilize the environment before coming back to do the definitive joint replacement.
All right, why don't we see, interest of time, what you did? So
we did a total elbow, and I used a triceps on approach, which is supine. You really release the heck out of the ulnar nerve, and then hyperpronate. You're essentially twisting the arm around itself, and then that actually allows great access to the distal humerus. And when you take out the articular components, you really make a lot of room to see the whole thing, and you're essentially dislocating the entire distal humerus out of the wound bed, so you have a lot of access there. So this is the approach that I used here. And then I did end up prophylactically cabling that distal humerus, just because, not surprisingly, we got in there and everything was little shell bits of bone. And I do get one fluoro view just to make sure that my ulnar piece is not in flexion and that I can get the spool in the center of the joint the way that I want to. And oftentimes you have to trim back a little bit of the internal portion of the articular portion of the tip of the olecranon so you can get things to sit low enough. So I'll have a burr available to do that.
Here's a final. Looks great. So just to sort of hit on a couple of things that you said. One, I do a triceps on also. I think there's a really good article out there by Graham King in Journal of Hand Surgery, I think 2014, but I'm not 100% sure the year, that looked at it. And it's basically doing a paraolecranon. So basically you come right down the lateral border of the olecranon and cut right through triceps and lift everything off. And it actually, I've gone to that exclusively. Graham King's a really smart elbow surgeon, and I learned a lot from him doing that. And it works really well. You can, extend the elbow out and rotate it around. I think getting the ulnar component low, like you said, is really crucial. Oftentimes you'll see people will flex these up because it's easier, right, to get them in. I've actually seen people cement these with the stem going through the bone out here. So I think getting that thoracoscopy shot with the trial is really important. Because especially in 91-year-old old lady bone, it's really quite easy to do that, to have sort of a false canal. So I 100% endorse that way of doing it. And then and then you talked a little bit about rehab protocol, but what's your rehab protocol for her?
Yeah, for me, and I'd be interested in hearing everyone's rehab protocol for their distal humerus. I tend to try to get things moving as quickly as possible. However, I want to balance that against the soft tissues because I don't want a draining wound, especially for her over an implant. And so I splinted her for a week. And then if you notice on the post-op x-rays, there's a little strip back there over the poke hole open wound, which is a little bit more radial than the actual incision that I used. So I kept her mobilized for a week, but then as soon as I saw her in her post-op visit, began full range of motion within a week. I don't like to immobilize elbows for more than 7 to 10 days or so at most.
Do you splinter in extension or just at neutral, or how?
For her, I just did neutral. just sort of a physiologic position, maybe somewhere between 70 and 90 degrees with a rotation in neutral. I felt like that was enough to take the tension off the back of the skin. And I don't usually do extension night splinting or anything like that. I think splinting anyone in extension for a week is really like hard on a patient, and then their hand blows up because they can't bend their elbow. So the whole thing, you're walking around like Frankenstein, or your hand blows up because it's dangling by the side of your arm the whole time. So mine is primarily just, at most you get splinted in about neutral for a week just to rest the soft tissues, and then you just start ranging as much as possible and using that arm.
Hey, Carol. Yeah. The only thing I would add, did you resect the radial head on that case?
No, I don't believe so.
Yeah, I've seen before some subsidence, and when the stem subsides, sometimes the radial head can start rubbing on that lateral component of the distal humerus. I don't know if anybody else has seen that, but I've seen that before. The patient had to be revised by taking out the radial head. I take it out routinely just because it's not really a stabilizer anymore.
It depends on the implant. So I tend to use the Right Medical, the Tournier, which is more of an anatomic prosthesis, which was made to articulate with a radial head replacement as well. So there's some, if you size it right, you have actually some lateral column stability. I don't know that that's super important in this one, but you're right. If it does subside, at least then now there's lateral column, radiocapitellar joint, even though it's metal cartilage. Whether or not that causes pain is another issue. But the one thing is that if there's some in some patients, younger patients, if you're thinking about doing any type of convertible stem where it's a sloppy joint or even a completely unlinked joint, then maintaining that radiocapitellar lateral column stability as a secondary stabilizer is critical, although most of these are being done for 90-year-olds, so it's probably less important.
Yeah, I agree. I think it depends on your implant. I think this was the Coonrad, right, Carol?
Yeah,
this is a Coonrad,
yeah, it's the old one. So no, I did not resect the radial head.
I think one thing that Carol did that I actually do quite often is actually prophylactically cable the humerus. It's especially these older patients. It's actually really easy to split the humerus with the broaches. So I tend to do that just from don't ask me why experience.
All right. So maybe just in general, because we're kind of at time, but what does everybody do? Is everybody just range of motion is tolerated as soon as possible? Is anybody splinting these out or night splint? And forget total elbows, but like John, what are you doing for your smashed, or if you're still on? I don't know. Maybe I've gone by now, but is anybody doing anything different than just trying to get them to move as soon as possible?
Sorry.
Go ahead, Milton.
I do an extension night split, just, for the first couple of weeks. Otherwise, I get them moving the next day. So everything comes off next day. They make a removable extension night splint. They start moving their elbow all day long, every day, and then wear the splint at night.
Yeah. All right. Mike?
I was going to say the only modification to my protocol, and maybe this is overly conservative, but if they have, so I am all about early active and passive range of motion as aggressive as possible, with the exception of the patients who get olecranon osteotomies. In those cases, I'll do active flexion and extension for the first 6 weeks. Now that is probably overly conservative, but I have seen that happen.
All right.
I have to tell you, the best range of motion results I've had are the patients who did not listen to me at all. They walk in at their 2-week visit carrying their 10-pound, 15-pound backpack in their hands, and they have perfect motion. So, yeah. So this is her 3 years later. Yeah. Yeah, she has a little bit of an HO right over the tip of the olecranon. I think that's because we were probably from torquing around the triceps, the extensor mechanism. But she's doing great. She just happened to be in town visiting, and she came by, no problem. She healed up great, no problems with that. And she still swims. She's kicking it.
Perfect. So I think just because we were a little bit over time, just for the take homes for this, you know, total elbow is a good option for some patients as long as you have good indications for them and have that talk that Carol talked about with the patient, right? Explaining what the realistic objectives are for their function and what they can expect as far as limitations. Whether or not they listen is a whole other issue. I think for me, those low fractures, those very comminuted fractures, and the poor bone quality is a really good indication. And whatever you do, and this applies for everything at the elbow, early range of motion as appropriate is probably the most important. And so I think we'll end there for today. I'll get back to everybody with regards to whether or not we're going to do one more session next week or then push it out to a little bit further. We were talking about this with Michael Gardner earlier. We'd like to keep this going to at least some extent, maybe, you know, within all of the West Coast residencies and continue fostering that level of interaction and collegiality, because I think it's been useful. It's been fun to kind of talk cases. I think if the residents, you've enjoyed it, or you have certain things that you'd like changed or different or added or subtracted, or you want me to talk less, I don't know, whatever, let me know. You should have my email. If not, your attendings have the email, and we'd like to tailor this to be fun and educational for everybody, but also continue to foster that spirit to kind of see what other people do and do that. So I want to thank everybody who's on here. John Scalaro had to leave to go operate, but he wanted me to give everybody his best wishes, and I just want to thank everybody for taking part in this.
Thank you,
Good
Jonah.
times.
This is
Thanks,
great.
Jonah.
Good job, Jonah.
All right, thank you.